What role does biopsy play in lymphoma relapse monitoring? Imagine trying to catch a sneaky disease before it causes more trouble. That's where biopsy comes into play. In non-Hodgkin lymphoma, biopsy is a key tool, but its role in monitoring for relapse is more nuanced than many think. While a biopsy is the most accurate way to confirm if the disease has returned, it's not used as often as you might expect during routine follow-up. Guidelines recommend that if doctors suspect relapse, they should confirm it with a tissue biopsy. This means taking a small sample of tissue from an enlarged lymph node or affected area to look at it under a microscope. But in real-world practice, only about a third of patients with relapsed lymphoma actually get a repeat biopsy at their first sign of relapse. Many doctors decide against it if imaging scans show no new or concerning changes, especially if the patient feels fine. Other reasons include difficulty accessing the biopsy site, the patient's overall health, or if the treatment options wouldn't change based on the biopsy results. Using biopsy as a routine surveillance tool has its limits. It's invasive, can cause discomfort, and carries some risks like bleeding or infection. Plus, studies have shown that doing regular biopsies to find asymptomatic relapse doesn't necessarily improve survival. For example, in aggressive lymphoma, a large number of PET scans are needed to find one hidden relapse, and false alarms happen quite often. This means many patients might undergo unnecessary procedures or worry over false positives. Instead, biopsy is mainly used when imaging or clinical signs suggest relapse. If a scan shows enlarged lymph nodes or new symptoms appear, a biopsy helps confirm whether the disease has truly come back. About 2/3 of suspected relapse cases lead to a biopsy, especially when the results will influence the next steps in treatment. Patients with relapsed disease are more likely to have a biopsy than those with refractory disease, which shows how clinical context guides these decisions. Because of these challenges, researchers are exploring less invasive options. Blood tests that analyze circulating tumor DNA are promising. These liquid biopsies can detect genetic material shed by lymphoma cells into the bloodstream. They may help identify patients at higher risk of relapse or even predict relapse before symptoms appear. This approach is non-invasive, easier to repeat, and could someday become part of routine monitoring. For survivors of lymphoma, the focus is shifting away from routine biopsies. Instead, follow-up care emphasizes regular clinical checkups, imaging when symptoms or physical findings suggest relapse, and prompt reporting of any new or unusual symptoms. Biopsies are now reserved for situations where imaging or clinical signs strongly indicate relapse and where confirming the diagnosis will impact treatment choices. Looking ahead, the future of relapse monitoring may involve combining clinical assessments with advanced blood tests that detect tumor DNA. These innovations could lead to earlier detection and less invasive monitoring. Still, tissue biopsy remains the gold standard for confirming relapse when needed, especially when treatment decisions depend on knowing the exact nature of the disease. In the end, the key is that biopsy plays a confirmatory role rather than a routine screening tool. Patients should stay engaged with their healthcare team, report new symptoms promptly, and understand that the best approach to monitoring involves a combination of clinical judgment, imaging, and, when necessary, tissue sampling. Always consult your healthcare provider for personalized advice, as each case is unique and requires tailored care.